Good morning. So the next session is dedicated to provisional stenting, the ultimate approach, part 2. The panelists are Ravi Nair, Dr. Alexandrov, Dr. Tarapunova. Yeah, we have one more. No, it's here. So the first presentation will be our approach in bifurcation treatment, case-based presentation.
Thank you.
Please.
Dear panel, dear colleagues. We have more clinical trials, consensus documents, special ABC documents and registry, and many evidence about bifurcation and how to treat patients with bifurcation. What is better for any group of patients, provisional one-stent strategy or two-stent strategy, and what is role of IVUS or OCT in this group of patients? ABC main study trial show us that is very safe to use one stent strategy for left main lesion. ABC2 trial show us same data that is very similar to use one stent or two stent strategy for non-left main bifurcation. But what is problem? This data only for elective patient. What is happened with patient with STEMI who had a bifurcation culprit lesion and need primary PCI? In acute coronary syndrome, main mechanism is coronary intercoronary thrombosis. Over 60% of patients in acute coronary syndrome had a large thrombus burden, and this patient had a 2 to 4 times increased risk for major cardiovascular events. In the acute coronary syndrome, this condition is a hypercoagulability condition, and this condition can be continued with made thrombus formation into coronary artery. During primary PCI, according this hypercoagulability, you must use the principle as less as possible materials and the maneuvers like unnecessary balloon dilatation or unnecessary using of imaging. In this way, we protect our patient, protect coronary artery to stop the develop new thrombosis or develop new no reflow phenomenon. I show you a couple publication and the trial and the registry about who is better, provisional one-stent strategy or two-stent strategy for patients who had bifurcation like culprit lesion in STEMI. This publication over the 1,000 patients, around 10% of patients in this STEMI group had a bifurcation lesion like carpet lesion, and over than 19% have a provisional one-stent strategy. Conclusion from this paper is that two-stent in STEMI is great contrast used and prolongated procedural time. Second publication, the big part of patients with STEMI in primary PCI, 10% had a bifurcation carpet lesion, over the 80% had provisional one-stent strategy. In this group of patients, no difference between two groups in a short and a long period follow-up of all causes of mortality. Next group is patient with STEMI and bifurcation, 132 patients, and 65% with provisional stenting. In this group, not difference between one stent or bifurcation lesion treatment. Publication with over the 14% of bifurcation like culprit lesion, over the 80% with provisional stenting technique. This paper concludes that primary PCI bifurcation in STEMI had acceptable success and MACE. Provisional stenting is favorable technique. And last is the COBIST registry. In this registry, 12% of patients had a bifurcation lesion, over the 80% had a provisional technique. In this group, what is problem? In this group, this is multi-center registry for Korean's country, and in period from 2003 to 2009, in the first 4 years, patient get first generation of drug-eluting stent. In the last 3 years, patient get drug-eluting stent second generation. Probably this data is cause of two-stent strategy had a significantly high rate of MACE than one stent strategy in all MACE, in target lesion revascularization, or in stent thrombosis. Only Dickey Crash 2 trial is a randomized trial with 63 patients with STEMI, divided in two groups. Half patient had a provisional stent technique, half patient had a Dickey Crash technique and follow-up, in short, in hospital follow-up, not different in MACE, in follow-up for 1 year, not different in both groups. What is with patient with left main stenosis? This is SCAR registry, biggest registry from the Swedish everyday practice registry for all cath labs in Swedish. Over the 4,000 patients had in this registry with left main stenosis, only 23% with chronic coronary syndrome, over the 76% with acute coronary syndrome. In this group had 10% with cardiogenic shock, and over the half patient had decision from heart team before the PCI on left main. In this group, 76% of PCI working in the working time is not ad hoc procedure, only 24% over the working time as acute patient. Our patient is oldest female with chest pain 2 hours before first medical contact. You can see ECG in the first medical contact. After admission in hospital, in non-PCI hospital in Negotin, patient had 4 episodes of ventricular fibrillation who stopped with cardiopulmonary restitution and 4 DC shocks. During transfer in cath lab in our hospital in Zaječar, patient had in the car additional 2 episodes of ventricular fibrillation, 2 additional DC shock. Our angiography show us ostial LAD and proximal part of LAD subocclusion by new thromb. This is according Medina classification 010 lesion. This is not true bifurcation, but is bifurcation lesion. We put two wires, first wire in the main vessel, second wire in the side branch. This is circumflex artery in this case. We choose the Syncero Pro 4x30 stent. Stent for bifurcation technique choose according the diameter of distal part of main vessel. We put this stent and expanded with 10 atmospheres. When you choose the stent for bifurcation, you must know we have two platform of stents. Closed cell design. This design had a very good radial force and low flexibility, and open cell design like our stent in our patient gets very good flexibility, and you can very easy to pass with wire into the struts in side branch. We finished the procedure with pot balloon fluido 5x8 at 14 atmospheres. In bench test in the last consensus ABC show us that we have one trick for pot balloon. If it's stent in proximal part of bifurcation, significance longest that pod balloon, you can made if you made the standard pod from distal markers of balloon you put in the carina, you can additional made stent elongation. You can prevent this with two pods. First pod you start from proximal edge of stent, and next pod is with distal marker over the carina of bifurcation. When you choose the pot balloon, you must know that stents had expansion diameter, maximal expansion diameter. In our stent, like our stent, who is the 4 millimeter, maximal expansion is over the 5 millimeter, like in our case. In final result, we finished the procedure with stent primo implantation, provisional one stent strategy. Duration of this intervention, primary PCI is less than 10 minutes. We don't use the intravascular imaging, and we follow KISS strategy, keep it simple and safe. What is with intracoronary imaging? Intracoronary imaging is necessary for elective bifurcation procedures, but with patient with acute coronary syndrome can be very useful for thrombus presence and thrombus burden, especially OCT device. Sky expert consensus documents show us that we can use save the intracoronary imaging for primary PCI, especially if you have stent malposition or stent thrombosis, or if you have a typical type of STEMI like SCAD, for example. Take-home message, provisional versus two stent strategy in acute coronary syndrome. You must know that over the 10% patient with STEMI had a bifurcational culprit lesion. Over the 18% lesion treated with provisional one stent strategy. No difference in MACE, short and long term MACE between one stent or two stent strategy. Bifurcation lesion is STEMI. You must follow KISS strategy, keep it simple and safe. You must know that acute coronary syndrome is hyperthrombogenic condition, and you can use intracoronary imaging or additional balloon if is necessary only. In this way, we protect patient, protect coronary artery to not develop new thrombosis or new no reflow phenomenon. Thank you for your attention, and I invite you in the next basics. This is the oldest interventional cardiologist meeting in Serbia. Next year will be from the 26th to 28th April in Hotel M in Belgrade. Thank you.
Thank you for this interesting case. Any comment or question? I have one. Are you using sometimes thromboaspiration? I know that it was condemned a long time ago, but my associate Thierry Lefebvre and myself, we were considering it as a very important device. The problem is not the problem of the device, the problem is how you use it. So, you know, if you go with the thromboaspiration, you are pushing very quickly, you are pushing the thrombus. We are not aspirating. So it's like you know, the rotablation. You have to be very subtle. So we go with thromboaspiration. Just here, at the ostium of the LED, you move 1 to 3 millimeters, and you get the thrombus. And after that, you have a better view of the situation. You don't know how long here it was evident that the thrombus was not long, but in other situations, you may have a very long thrombus. Sometimes you discover an aneurysm or a lot of things. So I think for me today, don't put in the garbage the thromboaspiration balloon. So, any other comment or question?
In one cat lab in Serbia, we had experience with Actiliza treated with large burden of intracoronary thrombus, selective over microcatheter put in the artery 10 milligrams of Actiliza. This is not better solution for this patient?
Comment?
Yeah, so what I have done is, though the literature is not supportive of thrombus aspiration catheter use, you can basically do it if you suspect a large thrombus burden. Anecdotally, we've seen if you have a large thrombus burden, if you do it carefully, I think you have less incidence of slow flow in the vessel because thrombus hasn't migrated. There are a couple of things that you have to be careful is when you have a large thrombus and you go down with the catheter, it is very possible you'll pull the thrombus out and it'll go down into a side branch and then situation gets worse. So there are a few tricks that you don't stop aspirating till you get it in the guide, make sure there is flow in the guide, etc., so that you don't trap thrombus in the guide or pull thrombus into the aorta, pull thrombus and push it in the circumflex. The other advantage of having a thrombus aspiration catheter is that if you do have slow flow, which happens quite often, and it's not because of thrombus migration, it is because of small vessel ischemia, spasm, activation of thrombogenic and vasoactive chemicals. And you can use that to inject pharmacological agent downstream, including TPA or this is old-fashioned, but 2B3A agents, nitroglycerin, nitroprusside, verapamil, a lot of things. So it is a useful tool to have. It's a useful tool to have, and with large thrombus burden, you can anticipate problems. You can.
No reflow is big problem in this type of patient, and we used this medication over microcatheter, but is not working every time.
Yeah.
Thank you.
If you don't use it, you will regret it.
Yeah. Thank you very much.
Thank you.
Just one comment, please.
Yeah.
I think thrombus aspiration was banned not very clever. It still has its uses. I find it personally very, when I do acute coronary syndrome STEMI with bifurcation, sometimes, you dilate the main vessel, you occlude the side branch. Then you dilate the side branch and then you occlude the main vessel. And my approach is to dilate with the balloon the main vessel and then do aspiration to the side branch. And I find it very useful.
Thank you. So we'll move to the next speaker. Will be dedicated to chronic total occlusion in bifurcation, which is a topic. George? A topic we like in Bifurcation Club, epidemiology and approach. Chronic total occlusion in bifurcations.
Thank you. So there is a lot of literature, I would say, in the last 3-4 years in the topic. So the bifurcation in the CTO, it becomes an interesting topic for the interventional community. Here you see a table that more or less summarizes the trials or the publications that they have been on the bifurcation in CTO. And the bifurcation rate in the CTO setting, it varies between 26.5% in older data up to 67%. So in data that are more contemporary. In my view, I would say that it comes more or less around 30 to 35% or so. In 1 out of 3 of CTOs, you will find that there are bifurcations. Here is a publication that actually classified the CTO, and essentially the message out of this is that you have to be in the proximity of less than 5 millimeters close to the occlusion in order to credit that as a true CTO and bifurcation lesion. In a publication that was a consensus paper between European Bifurcation Club and a EuroCTO club back in 2023. I think this is an excellent publication that I think people, they have to go, that they're interested in the topic, to see all the aspects related to CTO and the bifurcations. And there was a further, let's say, detailed analysis about the location of the CTO. So 1 out of 3 CTOs, they do have a bifurcation. And what you see is that more or less the recoil distributed between the proximal cap, the distal cap, and the CTO body, with the CTO body having a little bit of less bifurcation involvement. To me, that was a surprise, because these branches, most of the time, they're not easily available. But it has to, as it has to do with the distribution of the CTO, that's where we are standing. I will revisit this during my presentation. And there was an EuroCTO registry that essentially detailed even more. And you can see that, again, the numbers are very close, but over there, the intralesion was 16%, and both proximal and distal was another 9%. So the main thing out of all of these things is that the branches can be located anywhere, and these are increasing, let's say, the different options that you have in treatment. Also, what are the different treatment strategies? There is this excellent publication by Dr. Chico, or Professor Chico. I was discussing with it yesterday. I will not go into it because it's too complex. But anyway, what I'm trying to say is that I present it, and there is an effort to reclassify the bifurcations based on the classical Medina classification adapted to the CTO setting. And that's an example of the publication here. It is quite complex, but anyway, for me, the message that comes out of this is that more or less we have to adapt the CTO bifurcation lesions to the concept of treating with same rules and same principles, even the CTO bifurcations. The mechanisms of carina, of how a branch can be compromised in a CTO setting, it's more complex compared to the classical non-CTO bifurcations. You have the plug shift and the carina shift, but in the CTO setting you can have the subintimal shift, you can have a dissection flap that comes from subintimal wire tracking, or we know very well you can have intramural hematoma, which are much less or maybe non-existing in a no CTO bifurcation setting. Now, what do we know about this? Because what is interesting is when you have a CTO bifurcation in CTO, is it more complex? Yes. Are the success rate less or more? That's a question to be answered. And are the complications less or more? In an initial publication by Galassi in 2015, you see that the technical and clinical success was lower when you have bifurcation and there was higher complication rate. If you see what is mostly happening is periprocedural MI. And that is expected because when you lose a branch, then you expect to have an periprocedural MI, depending on the definition of all of these things. And another publication that came from Progress CTO, again, showed that the technical success rate is inferior to when there is no bifurcation. And the more the complex, if you have, for instance, the proximal and distal bifurcation in the caps, then the success rates are less and the complications are higher. But if you look at more carefully with more contemporary data, which is also my belief, is that you will find out that between bifurcation and non-bifurcation, the technical success rate remains the same. But if you go and you categorize these and whether, where is that located, because if you see the entire cohort, then you find no differences. But the intralesion CTOs, they have the bifurcation CTOs, they have less success rate, and this of course refers always to the recanalization of both branches. And also referring to the outcomes, you will find out that the lesions that are intralesion and proximal and distal, they have the less success and the more the complication rates. So not all of the CTO bifurcations are the same. The ones that in the middle of the occlusion or both proximal and distal, I will skip that. They are more complex and they have less success and more complications. This is another publication that comes from Japanese data where, again, the main message is that when you have bifurcation CTOs, essentially, you see that the success rates are not more different, but they are involving higher use of retrograde approach, which we know that is related with higher complication rates. So regarding what kind of techniques you have to use, there are sporadic also publications. You should consider that all of these are not big data. When you have for instance, in this case, mini crash was superior to stenting. Another publication shows that when you use more complex techniques in the setting of bifurcation, that the outcomes are worse. But I stay with the final statement of the consensus paper between EuroCTO and Bifurcation Club, that essentially the general principles of bifurcation treatment apply to the setting of CTO bifurcation. So let's keep it simple, and I do believe that is the true, although the setting in the CTO bifurcation is more complex. And the complications that you can have also, as you see, they tend to be higher when you have in CTO and proximal and distal, but there are specific complications, just like, of course, the side branch occlusion and dissection and the material jailing, higher rates of perforations according to what we think, and there is a retrograde wire jailing and stent deformation when you treat this complex lesion. I'm just going to present you 2-3 cases. If I become too long, I have time, I think I will manage it. For certain types of CTOs, this was a double CTO. You appreciate here, the main bifurcation CTO was the right, the circumflex. The right was treated by retrograde with reverse cart, and then we went to the circumflex, and you can see that the marginal branch is provided by retrograde through an epicardial collateral, and then this was crossed. Microcatheter was exchanged because it didn't cross the collateral. The distal circumflex, actually there is another branch here. You see here the distal circumflex was crossed antegrade, so you have a bifurcation that one branch needs to be crossed antegrade, another branch needs to be crossed retrograde. You see here that the retrograde wire is crossing. Probably this is reverse cart. You see that there is a reaching of the left main. And just to tell you, when you have this kind of antegrade retrograde wiring into the same vessel and you go through epicardial collateral, directly you see that more complex techniques are necessary. You see here the double catheter, the ping pong technique, and then finally kissing balloon, mini crash was applied in this case, and after kissing balloon we achieved a satisfactory result, and you see here the third branch. So another case, that was a kind of a more straightforward LAD CTO. When I saw it, I said, that's okay. But what I want to tell you is that from this one, even from this injection, you don't get any perception of the bifurcation. There was an antegrade crossing. I don't know what this is. I can just correct that slide, please. Can you play the next one? Because this slide, for some reason, is stuck in. Just start it again. So there was an... okay, after antegrade wire crossing and some predilatation, you see that we were able to see in a branch that it is coming here, big diagonal branch. A dual lumen microcatheter was used. This is essential, and there are many of these, as you can appreciate, that they're essential in the CTO bifurcation, but also more than the non-occlusive disease. So this was a kind of an intra-lesion CTO. and mini crush was again applied and kissing, and this is the final result, and you can appreciate that the diagonal branch was not evident. It is a very sizable branch that definitely can contribute to ischemia. So this is an intralesion CTO. I will present you another case, a post-cabbage, in a patient that you can appreciate the complexity here. That was done in South Africa. This is a case that undergrade wiring was a little bit hopeless, I can say, but we got a retrograde approach from one septal branch. And you see here the wire was not going easily. We make an injection here. As you can appreciate, here is the point of the grafting, and there is a retraction of the native vessel. If you can see it in more detail here. This is the graft that goes up there, and then this is the native vessel that makes the curving, and there is a bifurcation at this level exactly of the PLA and the PDA. That's to give you an impression of what you can face. That's, as I told you, the anatomy. That's the graft, that's the retracted vessel, and the CTO is here, and you have PLA and the PDA. And anyway, any retrograde option from the PDA was not possible, so the way that it happened, that's what I told you, intralesions, we have to go different vessel access. Here, in this case, we selected double retrograde. So the message that you have to get is that the complexity increasing exponentially when you have to go to perfection of these cases. So double retrograde and the PLA retrograde allowed bicoaxiality with the CTO. So we were able to address the CTO and then reverse cart over there. And what happened is that we dilated all the vessel all the way to the cracks. A dual lumen microcatheter and guiding catheter extension was brought exactly at the point of the bifurcation, and then you see that the retrograde wire from the PDA was able to be advanced into this guiding catheter extension, and that's how the wiring of the second vessel was done. And afterwards, there was an externalization, not to make the long story short. You see that two wires were externalized. They had to be exchanged into antegrade wiring. Because one of the things, as I told you, material entrapment can be an issue in these kind of cases. And afterwards, can you correct that one, please? Excuse me? Can you just? It was stented in the direction of PDA, and I'll show you the final result. No, not that much. Go here. Hello? Yeah. Just want to show you the final result here after stenting. I will present you another case which is also quite interesting. I have two more. Maybe I will abuse your time a little bit. This is a case that it was a bifurcation CTO, as you can appreciate here. And the complexity of this bifurcation CTO, there was grafting, that it was very close to the PDA. But on top of this, there was a stent covering the bifurcation of the CTO. So you add another layer of complexity to that. So it's not only about that you have a CTO, but in these kind of vessels, especially post-cabbage patients, that they have the grafts as you saw before, you add also a stent that it has to be crossed retrogradely. There was a wire that it went subintimal, and then it was actually decoiled, and it remained at this level. And what happened there is that you have to take the retrograde. Here again, two branches have to be crossed because the macrocatheters were not following. Here you see that we get retrograde access to the PDA, and I told you that when you have bifurcation lesion, you have more retrograde access, and if you see these details, it's not only to puncture the bifurcation, but when you have stent is how you puncture it. So you go reverse, actually, as you say, the proximal strategy here. In order to do it right, you have to go from the distal. If you go proximal here, you will not get access to the other vessel. You have to go to the distal strat in order to be able to get access to both of them, and that's exactly what happened, the reverse cart externalization, and just to go, you see the specifics, dual lumen microcatheter afterwards to get access into the PLA, and essentially that's okay, and then that's the final result. But you see the complexities that it's involving, and I'm going to present you a recent case that I did in Athens. I want that you see it Well, it's a left main, then the LAD. It's a dominant circumflex, not to make your life more easy or more difficult. This is a large marginal branch, and this is the distal circumflex, and there is a stent. So it's actually not only body, but it's proximal, distal, and body CTO with a stent in the middle of it. So the complexity can go as much as you like. You can clearly see here the stent. That's the last case. I will not take much more time. So what we did here, we went antegrade first of all, and then you see that in these kind of cases, ADR techniques, the section reentries, have to be involved. You can appreciate that the knuckle wire went down to the marginal branch, okay, and then it followed in a nice way, not very big branch. It didn't go to the big branch of the marginal, but it went into the side branch of it. Then we went with a dual lumen microcatheter to get access to the bigger branch of the marginal, as you can appreciate here, step by step. But it shows you the thinking that it has to involve when occlusive disease is existing in combination with CTO bifurcation with access to this branch. Just correct this one, please. Hello? Just 1 second also, that's the last, okay. Okay, then what we went retrograde in order to get access to the distal circumflex. You see that there was a kind of a strange takeoff of this big septal branch. We used an angulated microcatheter. You can clearly see it here to engage this ostium, and then a wire goes into this septal branch. This is exchanged to a microcatheter. There is a retrograde wire crossing from the septal branch. I think it was a Sion black. I don't recall the details of that. Let's see how it's crossing. Yeah, it goes down to the distal circumflex. A little bit of septal surfing. And it goes distally. So you see ADR, then dual lumen microcatheter, then retrograde. You see the retrograde wire. The microcatheter didn't cross. It has to be exchanged in a different one. Here is a fine cross instead of the Corsair. And then you reach. And what you see is that we do now reverse cart. There is the stent. Thank God it was not completely closed. And you go afterwards, as you will see. After that, you have to be careful to do the crossing into the left main appropriately. But all of this, it shows different complexity of that. We reach the aorta. Then again, you go with a ping pong, as I presented you into the first case. You enter the second microcatheter, because afterwards it was difficult to externalize here. Another technique was applied. So essentially, you see in one case all the various aspects of CTO plus the bifurcation, tip-in technique. Then the microcatheters were advanced, and then after exchanging all of that, the bifurcation treatment started. We stented the kissing balloon, and we stented in the direction of the marginal. It was mini crushed, I think. You can appreciate it here. The vessel starts to take any shape. This was crushed. Then it became with an stent implantation, the retrieval of the wires, and then also the proximal bifurcation. We have the bifurcation of the marginal, we have the bifurcation of the left main, and essentially you see again the restoration of the anatomy. One time in, we kiss the bifurcation. One more time, please. I don't know whether they're stacking. Let me just show you the final result. The previous one. Sorry about that. And you see here, after we kiss the bifurcation with the marginal branch, that's the final result in this bifurcation by restoring. So essentially, in one case, you have two CTO bifurcations and the left main bifurcation. So that's a little bit what I wanted to present you. And you got a glimpse a little bit of the complexities that are involving these kind of cases, depending on where they are, depending if there are stents, depending if there are post-CABG patients. And, but again, the principle is, as I told you, referring to the stenting techniques, keep it as simple as possible, depending on where we're going. But I think you got a glimpse of the complexity of the topic.
Thank you, George. We have question or comments? I have something I learned in performing CTO was when the side branch is in the corpus of the occlusion. When it's a big branch, like the big diagonal you have shown, this is justified to open it. But we learned the lesson from Bonkolku. If you have three diagonals, one of the three diagonals is missing, it's probably not necessary to open it. Because the system to collateralize the diagonal is much better than the system to collateralize the LED. So if you open a very small diagonal branch, you will not bring something to your problem. But if you close the LED, you don't open the LED, then this is a mistake. So in the corpus, with a small diagonal, personally, I was not touching.
Yeah, you're absolutely correct. The selection of what you are getting as a target, especially when you have combination of CTO and bifurcation, is more, even more complex than in the non-occlusive disease. But the general thing is that you have more peri-procedural MI when you have bifurcation CTOs. By this way, even if they do not contribute extensively to the long-term outcomes, they are creating more peri-procedural MI, and this related to a certain extent, depending on on how big the MI is, in adverse effects in the long term. But in principle, I agree that ischemia should be, again, one of the denominators to choose if a target of a side branch is a target or not.
So, George, along those same lines, the temptation is always to do multiple stent strategy, not this provisional in CTOs, because the side branch occlusion will lead to an MI, and the temptation is to put two stents if the diameter is adequate, correct? Maybe sometimes the proximal...
Maybe what I did, what you saw in these kind of cases, I wanted to present you different scenario, but they were into the more complex direction from what also might be usual. I had a series of cases actually that you could overcome these without bifurcation stenting, but here you saw true bifurcations that they were involving all branches, so from within the lesion, from even proximal distal and in CTO with stents. But there are many cases that essentially I was doing 2 days ago, a very nice case in Cairo Life, and then actually we were able actually to avoid completely. We did it with simply bifurcation CTO with DCB, both of them.
I was just asking.
Simply, I didn't.
Are you moving to DCB for side branches?
Yeah, I didn't have the time to present the case to you because I have the CD, but I didn't have a CD player to edit the case. But we are moving into that direction, and I think if we were doing these cases more contemporary, I think DCB would have been a bigger player. Because avoiding the metal, I believe in the principle of less metal, better results in the CTOs. Thank you.